Hello, my name is Dr. Zachary Shulman, and today we're going to talk about chronic cough, and I'm going to be walking you through how to approach a case of chronic cough for the NAC OSCE exam. During the exam, you'll have approximately 2 minutes to read the case that's in front of you and take some notes. So let's take this case as an example. John Smith is a 68-year-old male who presents to his GP with a cough for the past 8 weeks, and your task is to take a history in the next 8 minutes. So in the next few slides, I'll be guiding you through how to take a history for a chronic cough. Okay, so before we start, it's important to keep in mind that everyone might have a slightly different approach to taking their history. Some people might ask questions in a slightly different order or prefer to group their questions slightly differently, and it's important to find the approach that works best for you. And the only way to do that is through practice. So what I'll be talking about to you today in my presentation are all the key questions that you should be asking when your patient has come in with a chronic cough. And I've grouped the questions in a way that worked best for me. So of course, before we even get into the history, it's important to start with your introduction. That should be the same for any case that you're doing on your NAC OSCE exam. And then you're going to start with an open-ended question. So, John, what brings you in today? He's going to tell you he's come in with a cough, and it's been going on for 8 weeks. And then you want to start your history. And we start our history by asking all about the cough. So you want to ask onset, setting, course, and duration. So when did it start? What were you doing when it started? Or do you remember what you were doing when it started? Since it started, is it all the time? Are you coughing all the time, or is it on and off? Typically, the duration will be given in your question stem in front of the door, but if it wasn't given, then you can ask how long has the cough been going on for. Then you want to ask about if the cough is dry or productive. So have you been coughing up any phlegm, or is the cough dry? If it's productive, then you want to ask about the color, the odor, the consistency, and the amount, and if there's any blood. So you're going to say something like, what's the color of the phlegm? Does it have any particular odor? Any particular consistency? How much phlegm would you say you've been coughing up? A lot, a teaspoon, an espresso cup, and then you want to ask if there's been any blood when they cough up their phlegm. Then you can ask about pain. Are they experiencing any chest pain or chest tightness? If so, then you ask about the position of the pain. Where is it? The quality of the pain. What does it feel like? Is it sharp, stabbing, burning, dull, aching, throbbing? Does it radiate or travel anywhere? And on a scale of 1 to 10, with 1 being no pain and 10 being the most pain ever, can you rate the severity of your pain for me? Typically, that's a good opportunity to give some sort of empathetic statement. So if they say, oh, it's the pain is a 4 on 10, doctor, you can say, oh, I'm so sorry to see that you're suffering or that you're in pain. We're going to do everything we can today to try and help you. You can also ask about pain on inspiration or expiration. Then I like to have a heading on my notes when I'm outside the room. I like to write time, because that's typically an important question with any case. And in a chronic cough, you would want to know if it's the first time they've experienced a cough like that. And another type of question that comes with time is what time of day the cough occurs at. And that can give you a clue to cough variant asthma, which typically occurs in the middle of the night, like 1, 2, 3 a.m. Then you want to ask about triggers. Have you noticed anything that might trigger your cough? Maybe exercise. You can ask about asthma triggers, dust, outdoors, renovations, carpets, new sheets, pets, smoking, stuff like that. You can ask about NSAIDs or ACE inhibitors. You don't typically need to ask all of them, but these are just some ideas. You typically start with an open-ended question, and then you can ask a few of these examples, and then you want to ask if there's been any alleviating. Does anything make the cough better, or does anything make it worse? And then again, I'll start with the open-ended question, and then you want to pin, so they'll say, does anything make the cough better? No, I can't think of anything. Anything make it worse? No, I can't think about anything. Okay, what about lying down? Okay, and they say, actually, my cough is worse lying down. So then you could think about congestive heart failure, postnasal drip, or GERD. Those are all clues to when a cough is worse lying down. Okay, so now we get to the next part of our history, where we're going to ask about other symptoms. And I like to divide my other symptoms into local symptoms and into constitutional symptoms. So let's start with the local symptoms. You're going to ask if they've noticed any shortness of breath, any wheezing. What about any noisy breathing? Have you noticed any sore throat, any runny nose, any ear pain, any pressure or pain in the face? How about any muscle aches, any ticklish sensation in the throat, or you feel the need to clear your throat? And that could give you a clue to postnasal drip. How about any heartburn or acidic taste in your mouth or change in your voice? That's indicative of GERD. Have you noticed any ankle swelling? If so, how high have you noticed the swelling goes? Does it go to your shins, your thighs, or higher? Have you noticed any shortness of breath on exertion? How about any shortness of breath lying down? Have you noticed that you need to sleep with many pillows at night? And those are all clues to congestive heart failure. And if your history is leading you down that path, then you should definitely be asking about other cardiac symptoms like chest pain, palpitations, nausea, vomiting, and sweating. And then we move to the constitutional symptoms. You're going to again ask about nausea, vomiting, fever, sweats, weight loss, change in appetite, lumps and bumps. Constitutional symptoms are super important for any case that you get on the NAC OSCE exam. Okay, the next part of the history I like to call recent. And usually recent things are really important to ask in any presentation. For chronic cough, you want to know if they've had any recent travel outside of Canada, any recent illness, recent flu, recent cold, any recent sick contacts, or anyone else with similar symptoms. Then we can ask about vaccination status and TB questions. So for vaccines, we want to know if they've been vaccinated for pertussis before, or if they've had their pneumococcal vaccine. Then we can ask some questions to look for TB. So you want to ask if you've ever been screened for TB. Have you ever been in contact with someone with TB? And have you had any previous chest X-rays? Why have you had the X-ray, and what did it show? Next, we're going to ask about specific risk factors that might guide us towards a particular diagnosis. So we can ask about smoking. If a patient confirms that they smoke, you should always ask when they started, how many cigarettes do they smoke per day, and have you ever thought about quitting? And if they say no, then you can say something like, if you ever want help with quitting, just know I'm always here to help. Then you want to ask about their occupation. So you want to say something like, how do you support yourself financially? And then be more specific and say, have you ever worked in a shipyard or a mine? Have you ever been exposed to any radiation? How about any exposure to asbestos or industrial chemicals? And any family history of lung cancer. So the next part of the history we typically ask when the patient's answers has led us towards a presumed diagnosis or a diagnosis of cancer. So maybe the patient had said that they are a current or former heavy smoker and they had positive constitutional symptoms. So we need to rule out cancer as being one of our main differentials. So you want to start by asking cancer screening questions. So have you had routine cancer screening done? And then more specifically, if they met the Canadian Task Force guidelines, you want to ask if they've had lung cancer screening done. Then we want to ask if about metastatic spread of the cancer, if that's what we're thinking is the diagnosis. So it's important to ask if they've had any headaches or seizures, any back pain or bone pain, maybe any yellow skin, dark urine, pale stools, or any symptoms of hypercalcemia like abdominal pain or constipation. So next we want to screen for risky behaviors. This is typically to rule in or to rule out HIV, which has caused PCP and is now causing their chronic cough. So a nice way to do this would be to start by asking the patient if they know what their HIV status is or if they've ever been tested for HIV. If the patient says yes, then you should ask follow-up questions. When were you diagnosed? Are you regularly followed up? Do you take any medications? Then you can ask about the CD4 count and the viral load, and ask about opportunistic infections like headache, blurry vision, neck stiffness, oral thrush, pain swallowing, diarrhea, rash. If the patient doesn't know their HIV status or has never been tested, then you can screen for that, and you can say, I'm going to ask you some questions that may be personal, but they're important to ask. And you want to start by asking about if they've ever been hospitalized and received a blood transfusion, if they have any tattoos or piercings, do they ever used IV drugs, did you ever work in a job where you were exposed to bodily fluids or blood? And then you want to ask about their sexual history, so with whom do you live? Are you sexually active? How long have you been together? Are you in a monogamous relationship or do you see other people? Do you practice safe sex all the time? What is your sexual preference? Have you ever been diagnosed or screened for STDs? And then what about your partner? And lastly, we come to the end of our history. It's important to note that some of these questions, if you've already asked them, obviously you don't need to repeat them. But if you've forgotten to ask them, then they're essential to ask. So we're going to start with the past medical history. Have you ever been diagnosed with any medical conditions? Do you take any medications? Do you have any allergies? Any previous hospitalizations or previous surgeries? And then the family history. Has anyone in your family been diagnosed with any medical conditions? And then in the social history, you want to ask about smoking, alcohol, and drugs. You want to ask how the patient supports themselves financially, with whom do they live, and about their diet. So based on all of the questions that you've asked during your history, your patient has guided you towards a diagnosis. So here I've made a list of the more common differentials and some clues in the history that point towards them. So let's go through the differentials. Lung cancer, the patient will be a smoker, current or former, as well as have positive constitutional symptoms. For TB, the patient might have recent travel outside of Canada, or might have had exposure to a TB patient, and have positive constitutional symptoms. For COPD, the patient will be a smoker, they'll have shortness of breath, as well as a productive cough. For pneumonia, the patient will have a productive cough as well as fever. That being said, pneumonia is typically more of an acute presentation than chronic. For PCP, the patient will have a dry cough, positive constitutional symptoms, as well as risky behaviors like IV drug use, or a male who has sex with other males. In terms of postnasal drip, they'll have a morning cough, maybe ticklish sensation in their throat, frequently clearing their throat, or recent history of sinusitis or chest infection. For congestive heart failure, the patient might be complaining of shortness of breath on exertion, a cough that's worse lying down or with exercise, as well as ankle swelling. For GERD, the patient might be complaining of a burning sensation in their esophagus or stomach, acidic taste in their mouth, change in voice, or a cough that's worse lying down. For cough variant asthma, the patient will have a dry cough, which often occurs at night or after exposure to certain triggers. And for an ACE inhibitor-induced cough, the patient will have recently been started on ACE inhibitors. Okay, so I hope this short presentation helps you for your exam. The aim was to give you a structured guide on how I approach this type of case on my exam. So thank you for listening.